Okay, I'll just give you briefly so that you don't waste too much time. This is 33-year-old male patient who has come with recurrent abdominal pain, was of course having also Crohn's disease in addition, and an X-ray showed that he had diffuse calculi in the pancreatic duct, all over the pancreatic duct. So now he's been put for pancreatic endotherapy here. He has an atrophic pancreas. So before we start the case, I think it's important to show this case why we are going to fail, because that also becomes very important. I'm with a great group of people here. I think Raken is supervising me, helping me out. Gary and Jonathan are the technicians. Mohan is there, of course, for moral support and also to assist with a little of the wires. And Ria, the anesthesia is by Riyadh. Yeah. So a great team here. In spite of a great team, sometimes you don't always succeed. Can you look at the papilla? Can the camera show the papilla here? Endoscopy picture, please.
So Ranjinder, he is a 33 years old man with the calcification,
yeah, 33 years young man. He's not old, 33 years.
33.
Yeah, 33. 33. So you can see, if you can actually look at the endoscopy picture, you'll see two openings there. The opening on the top is the biliary opening that was somebody did a sphincterotomy trying to get in. They couldn't get in, so they opened the bile duct. So this is something that should never be done. If you have a difficult pancreatic cannulation, if you do a biliary sphincterotomy, subsequent cannulation becomes very difficult because the orifice shrinks, goes inside. But we are fortunate that we could identify the orifice, so my sphincterotomy is through the pancreatic orifice there, as you can see it. Can you see that now?
Yes. Yes.
Yeah, so you can see the... And then we have taken an acrobat wire. I'm using a clever cut sphincterotomy. I'm using an acrobat wire. And if we now get back to the fluoroscopy picture, you'll see that the wire is going and there's a stone right at the tip of the duct, right at the tip. So it was initially very difficult to pass the wire, but Jonathan managed to pass it a little. And now we'll try and manipulate the wire. Now this is a case where we won't even do ERCP. The patient will go for extracorporeal shock wave. We can pulverize all the stones and very easily remove it. There's no problem at all. So, but anyway, because of this workshop situation, we'll try. Can you pass the wire now? Jonathan, try. Is there? Jonathan is trying to pass the wire.
So Rajinder, when you cannot cannulate with the sphincterotome, what is the criteria you go with the cannula? A straight cannula with 0.02?
No. Sphincterotome is a cannula only with a wire, that's all. There's no difference. So if you can't cannulate with a sphincterotome, we sometimes try a ball tip wire. But ball tip wire is ball tip cannula. But once you can't, always everything we do with a sphincterotome. Occasionally, when there's a very tight stricture you can't get through, we use a ball tip cannula. Now in this case, what is happening is I have my sphincterotome fairly deep inside. Jonathan is trying to pass the wire, but as he's passing it, he's pushing my sphincterotome out. So can you do it gently, Jonathan? Very gently. See, do what you must do is wriggling movements, wriggling movements. Yeah. One of the dangers of stones with a wire like this is the wire can get cut inside and be left the tip also. Keep doing that. Keep seeing if you can progress further. So he's not progressing further. Okay? No? Okay. Then give some contrast and see if a little contrast goes, we can follow the contrast. If the contrast is not going in, that means we cannot go. Give some contrast. Injecting, can you magnify a little that area if possible? Yeah. You're injecting? A contrast going inside? Yeah. So now I'll pull back a little. Now inject again and see. So I'm hitting against the stone, so I'm pulling back. Yeah, please inject. Anything going in now? Coming out? Yeah. So now what I'll do is I'll do something. Mohan, you want to try the wire a little? So we'll try and manipulate the wire, because unless the wire goes inside, you can't do anything in this case. I think Hassan showed very nicely pancreaticoscopy and then how we did the pancreatoscopic Yeah, now see that's happening. There's a very small opening there. If we can get in, it will be good. So, but you can see in this case, we can't even do pancreaticscopy because the stone is right at the orifice there. And the wire is hitting the wire and the sphincterotome are being hit by the stone. Can you now? So you are making a loop there. Yeah. So what I'll do, I'll just bend the sphincterotome a little more down so that you can have a different route. Can you take out and try again? Take out and see if you can get it now. No? I'm just changing the direction of my sphincterotome a little. So sometimes a small gap it goes in. The other thing we can do is, don't push further. I'll go in further. And yeah, now I got in a little more better position. But again, I think you can see small whitish particles also in the sphincterotome. Those are small stone particles.
So I have a question. If we failed, for example, to cannulate, so can we go easily with ISWIL?
Oh, I didn't get. What did you say?
So if we fail to cannulate...
No, this is actually, in fact, the first thing we had to go with ISWAL in this case. What ISWAL will do is, these are very nice stones which can be broken up completely with ISWAL. Now, even if the stone is partly broken, we have sometimes done this technique where we pass the wire inside and then we use a Sohendra lithotripter and screw it through. That will fragment the stones. But the wire has to go. The wire is not going at all because it's stuck up there at the pancreatic stone.
So, in this young man who is 33, what is your differential here? What we are worried about? What is your differential?
No, differential is got chronic pancreatitis. The question is whether you want to now, if you have a facility to do good ESWL and break the stones and clear the duct, he'll get relief of pain. Other alternative, of course, is surgery. If you don't have that, he'll also do very well with a longitudinal pancreaticojejunostomy because the duct can be completely opened up and all the stones cleared. But you see, when Mohan is doing also, he's hitting the stone. You're hitting the stone. He's not going at all. The differential diagnosis does not exist because it's just a chronic calcific pancreatitis. Most likely the tropical variant. Great. He's managed to get. Can you see that?
CVD.
Amazing, yes.
So just go in and see. No, it's not CVD. It's pancreatic. Yeah.
Oh, very good.
Okay, very good.
So, Dr. Mohan, what is the secret for your touch? And I always, there is only one endoscopy nurse who can do this. And I don't have Mohan in my endoscopy, but you are excellent. What is the trick? What can we tell the nurse to do to pass a stricture like that?
No, we kept on trying and that there is a stone.
Mohan, we cannot hear you.
We cannot hear you.
Yeah, okay. So
Still we
there's
can.
a stone which is blocking the orifice, and we kept on hitting that. And after some time, it gave way.
Yeah, there's another stone on the top there also.
Right.
So what we'll do at this stage, do you have the Boston 345 cannula?
So we went around it actually. See.
Yeah, so there's special tapered cannula which comes from Boston called 345.
LES, yes.
This goes on this 025 guide wire. Huh?
Yeah.
So you see now the sphincterotome is going up to that stage and is hitting the stone. You can see the fluoroscopy nicely.
Yes, it's very obvious.
Can you see? And then you can see how the sphincterotome is just at the stone level. So now in this case, we can try the very tapered cannula, the 345 cannula, to see if we can pass through. Because if you can pass through, you have the Sohendra screw.
So question, do we inject to see if we are not in a side branch or something like that?
No. Okay. We don't want to inject till we cross this main stone bulk because we know it's in the main duct, the way appearance is. But till we pass that, I don't want to. Yeah, this one, right. So fortunately, we'll try that. So now Mohan will keep the wire in place. Mohan, can you pushing the wire? No? Because there are some stones in the sphincterotome, it won't be so easy to keep the wire in place.
So it's going in the tail now.
Yeah, no, let it keep pushing it. Keep pushing. Excellent.
So you didn't tell us the tricks to tell our nurses to do.
So what the technique is that you must vigorously move your guide wire up and down, and same time give it a little twist. So some people, they find it difficult to twist the wire, so you have a wire twister also available with the guide wire. You can put it on and keep moving the wire and up and down and twist it. Suddenly it will get a pathway through which it will go through. So now, but it's a very, very small opening there beside the stone. So we'll see if we can pass this special catheter through. So that will give us some dilatation with that. If you have a Sohendra dilator, Sohendra stent extractor?
The screw.
Screw? Yeah.
So from the picture, how many stones do you think? I see 3, 4 now, or
many stones. There are many stones are there, but with ESWL everything can be broken, no problem.
I will hold it. You can bring the Sohendra retriever. Give us the cannula, taper down.
Fluoro, please, fluoro. And you can see I'm watching the fluoro, just fluoro there. Fluoro. Yeah, see, this is a very important point I want to emphasize. Look at the guide wire. You see the guide wire has formed a loop. Always you must form a loop with the guide wire, because then that means you're not in the side branch. That means you're in the main duct. That's an indication. So this is a...
So the real management in a patient with chronic pancreatitis with calcification and multiple pancreatic duct stone, how do you approach this case in the long run?
So this case, the options, if you have a very good extracorporeal shock wave and you can clear the duct completely, in our unit we'll do that and completely clear all the stones and free the duct. Now, otherwise, the second option in a young patient like this who's symptomatic, I would suggest even a surgery in form of a pancreatic or jejunostomy. He doesn't have a head mass, so phrase won't be a issue. It has to be just a pancreatic or jejunostomy. Now, the guide wire is deep. Can you see the guide wire? Now it's gone up to the tail. And based on the architecture of how the guide wire has gone in, I'm sure it's in the main duct. But we'll see. I'm hoping that I could get this catheter out there, and if you get a catheter deep inside, I can even inject some contrast. Can you push a little? So, now you see the catheter, very tapered catheter. Let's see if it goes inside now. Now I'm just twisting, using a screwing movement to try and get inside. It has got, that is a point where there's some obstruction. See that? Yeah, that's an obstruction.
So we're using the catheter for dilatation or dilation?
Yeah, for dilatation. This is a dilating catheter. We're using it for dilatation, but again, very difficult. I'm not able to get it through. So, very, very difficult. Other thing is, has this patient been given indomethacin? We like to give rectal indomethacin if possible. Now, just see how it's gone a little inside.
Gone a little.
Little, but very little. And you can see the whitish fragments also coming out. No. So we also have a special dilating catheter at home, which is a catheter which turns like a screw, and then you can go inside. You don't have a Sohendra stent extractor. You have Wilson Cook company
Dr. Reddy?
Yeah.
What about sphincterotomy, pancreatic sphincterotomy?
No, that's not going to help. No, that's not going to help, because you already have a partial sphincterotomy earlier. See this? If I'll come close to see the area, the bile duct opening is above, the pancreatic duct is below, there is a partial sphincterotomy. So that's not going to help. In fact, that may cause more problem because the catheter won't fit in snugly then. My problem now is, in the head region, I got a very, very tight stricture. Not stricture, the stone causing total obstruction. I'm not able to pass even this dilator tapered through. The only way to pass this without ESWL is to use a Sohendra stent extractor. You can actually screw your way through and then put in a stent. But Wilson Cook So if you want, what we can do is we can search for the stent extractor and try and get it. If you want to change the room and come back again.
Okay. So control, change the room.
So this is, you can ask Wilson. See, the stone is moving actually. I can move the stone. Can you see the thing now? Yeah. You can see the stone being moving. Can you see that?
Yeah.
Very impressive, the stone. Yeah, you can move the stone. In fact,
Reddy and Dr.
yes.
Mohan.
So we tried with different catheters and not able to go in. So we put in a cystostom, 6-French cystostom, to see if we can burn our way through. Can you have the endoscopy picture and the fluoroscopy also? Fluoroscopy? Both. No, I don't think they're seeing it. Endo and fluoro. You can see that.
Can we have the fluoro picture? Yeah, yeah, we can see it now.
You can see, and then the endo also you can have. So you can see I'm not able to still push the cystostom through. So I'm going to use, Gary is putting tension on the wire here. I'm going to use a little burning current like a cystostom. So this will crush probably, yeah, now I'm burning. Let's see if it goes inside. Yeah, okay.
Oh, well.
Oh, good.
Nice.
So it's gone inside now. So you see now, we have dilated the track using a very unconventional method.
Very nice out-of-the-box thinking.
Yeah, you have to do out of the box. I won't recommend this for everybody, but if the duct is very dilated, atrophic gland, then you can think of this. So now we have created enough space with the cystostom to dilate this much more, and then we use the cystostom to dilate. So you can see actually some whitish flax also come from
Gary,
the
tension the wire, please. I can't help myself.
You want to do cholangiogram or pancreatogram?
You can put in a little contrast there.
We can put
yeah.
here.
So you got another port for putting in contrast. Yeah. So Gary is very good. Yeah. So you have excellent staff.
Gary is one of the most senior endoscopy nurse in the unit. I think he's been here before the unit.
The doctor? Yes. See the duct now, very nicely seen. Oh. Like a doctor, yeah.
So when you inject the pancreatic duct and you have
very nice.
No, you put
you have many pancreatic stones and am I afraid from infection or do I need to?
No. This is one thing with pancreatic ductal, unlike bile duct, infections don't occur, very, very rare. But anyway, we're going to put a stent to drain this off completely. Yeah.
Saline. Just wash.
So what actually Gary is now doing is injecting saline, pushing the wire a little inside. So as I come out, see the fragments coming out, small whitish fragments keep coming.
Can you see the endoscopy picture? What the saline flush does is...
Yeah, it's obvious.
Yeah,
yes.
push the wire, flush a little more saline.
So
it
will make some space.
Yeah. Yeah, little.
See that the fragments are coming out. It's like a lithotripsy.
Yeah, saline lithotripsy. Keep pushing the wire. I'll take out this one.
So what will be? What you are guys planning to do? Just more crushing using a cystostom now, or just flushing?
This is cystostom. We have crushed a part, made a pathway through. So the next step would be for us to see if there's enough pathway to put a stent now. The stent will give good relief till we plan a definitive therapy.
So what type of stent are you going to place?
So we are going to place a single, I always use a single pigtail 5 or 7 French stent. I like to use single pigtail for pancreas because the migration rates are very less. I'm coming down now, okay. So the last part you have to be careful because what I will jump down and the wire will then slip.
So, Rajinder, tell us when there are multiple pancreatic stone here. Still you will not try to remove 1 or 2, or you go ahead for
it's
stent?
impacted. The thing is, the stone is impacted down. There's no point in trying to remove 1 or 2 stones. We have to completely clear the pancreatic duct.
Give us balloon.
And the best way to do that is to do extracorporeal.
No, this one balloon, G-flex balloon.
So you can see that whitish small things coming down because part of the stone got crushed.
Is there any rule for pancreatoscopy or?
No. Which one?
Pancreatoscopy.
No. The stone is right at the mouth of the papilla, so the pancreatoscope will hit it directly. You can't. We can use a fully covered stent, but because stone disease, what happens is it doesn't open up completely. Our purpose is to drain the thing. If it is a pure stricture, I would have preferred a fully covered stent.
So, Rajinder, this is dilated PD, and multiple stone, many strictures, chronic pancreatitis. He's 33. What will be his prognosis?
Prognosis, if you can clear his stones completely and create a free drainage of his pancreatic juice, overall prognosis is good. Only thing is, these people are more prone for malignancies, higher incidence than regular type of chronic pancreatitis. So I would monitor him carefully with 6 monthly CA99 and imaging. Okay, this is 6 French. The new one.
So again, what stent you are placing, Dr. Reddy, like double phalange?
I'm placing a single pigtail stent, but first I want to dilate it a little more, that area tract. Because although we burnt our way through, sometimes even after burning, you'll find you can't pass the stent easily. So I'm just trying to pass catheter. See, again it's getting in that area. Slowly we'll see. Slightly pull.
Yeah, went.
Very good.
Very nice. Very
so
nice.
now,
Good
so
contrast,
that
good contrast.
we could pass through. Now we create a contrast so we can open up that area completely and then put a single pigtail stent.
So the dilator is 4 millimeter.
What is the stent you have?
So what about
longer one also? You have longest one. What is it? You have the centimeter.
Yeah.
7. You have 9 centimeter. Yeah, 9 or 10, whatever.
So what about a double phalange stent to avoid migration out?
5 French, 10 centimeters.
Yeah, so migration out doesn't matter because it's very tight. It don't migrate out. We leave the we leave the inner flap there. But what I'm more worried about is migration. Stop. I'm more worried about is it doesn't migrate in. That's best because then you can't remove it. So that's why straight stent you should not put in this situation.
So this is 4 millimeter dilation?
This is a balloon dilatation now.
4 millimeter.
6. This is 6 millimeter. Single pigtail. We should always put single pigtail. And you can see now we have created a pathway. It is impossible to pass that area. The important thing in pancreatic endotherapy is patience and sometimes out of the box thinking, because unfortunately most of the accessories that have been made for biliary, not pancreas. Okay, you can deflate now.
One more tandem dilatation.
You want up? Okay.
Any concerns while dilating by pushing the stone into the wall?
Yeah, after this patient will improve dramatically, but we have to think of a long term.
Yeah, very good.
Yeah, now dilate.
Enough.
Yeah. So we go up and dilate that segment also. Gary is also very strong. Probably gym he's going to every day. So you can see that's why he's able to do. Yeah. Yeah, good. Okay, yeah. Okay. Then we can deflate, come out, and then we'll put the stent inside. So he'll have very good relief now. Long term, we have to plan what depends on what he.
You can send to Hyderabad for ESW.
So in such a scenario, just one stent is enough?
One stent is enough. One stent is enough. Actually, a lot of sweating you did to get in one stent.
So how long you keep the stent in pancreatic?
The stent 6 months. After 6 months, we want to change the stent. Or by that time, we should plan a permanent treatment. As a young patient, if he was elderly, I would have waited.
So in PD, you can keep the plastic stent 6 months. It will not be infected, right?
No, you don't get infected 6 months. So bigger size. Biliary? Well, which one do you have? You don't have a longer one? 9 French? Okay, then because 7 will be short, we'll have to put a longer one. Biliary, because I want to use a single pigtail only. Because no, you should not.
Yeah, probably I think it's probably doable to use a 7 French biliary stent.
Yeah, 7 French. You have a 7 French 9 centimeter? 7 French single pigtail? No, single pigtail. 7, what is the longest you have single pigtail?
Where? Okay, sorry.
So what's the advantage of pigtail over the biliary stent? So why do you want
So
pigtail?
internal migration only there. In the pancreatic duct, internal migration causes a lot of problems because we cannot take out this stent. If it gets internally migrated among the stone masses that we see, only surgery we have to use to take out. So that's the reason why I feel that it's better to use single pigtail won't migrate inside. So the pigtail is the duodenum, the straight part is inside.
We have pillar, you didn't have so we can.
Now, and then you can replace it after maybe weeks.
You have straight one, huh?
9 or 10.
Okay. 10, give 10. 10. Give a long one. I'll leave a long segment outside. Then, no 10. 7, 10. 7 French, 10 centimeter. Okay.
Yeah, I think very good option to have a long stent so it doesn't migrate.
So we always are worried about internal migration for pancreas. Whereas biliary internal migration, no problem. Nowadays, we can very easily remove it. But external migration is a problem. Okay.
How about pancreatic duct with internal flanges?
We leave the internal flanges intact. That's very important.
For the sake of audience, Rajinder, when I want to measure the PD stent, I want to put on the CBD stent. CBD stent, we go with the size of the vertebrae and the vertebral disc, and we can. But when I want to put the PD stent, where should be the end?
Yeah, that's a very good point. So PD stent, you should put it in such a way that it does not hit in the genu, because when it does that, it goes into the side branches. Either it has to be very short, 5 centimeter, or 9 to 10 centimeter. It should not be in between, because the stents which are like 7 centimeter will hit against the genu. So that's why we are using a long 10 centimeter stent in this case.
So thank you, Dr. Reddy. We'll come back to you to see.
I'll finish it off.
We'll just go to just look at the tip of the.
One second.
Sure, yeah, that's fine.
Just I'll finish it.
Absolutely.
So the patient can be then.
All the rooms need 1 second. Actually,
you can see that
me.
It's similar.
All the room needs 1 second.
Yeah, pull. Pull, Gary. No, it's okay. It's looped there, so no problem.
Very nice. It's going.
Yeah, now you can pull back. Now you can release the stent, So you see, this is a stent which goes on a guide wire, an internal sheath, and then the stent outside. So that gives it stability. So this is again very useful in this type of situation where you find that you require a lot of strength, lot of...
Rajinder,
so you see the movement I'm making, the screwing movement, very important.
Rajinder, I feel the end of the wire is hitting the tail. Is going to go from the mouth.
It's loop. That's why he's going to take it back now. So Gary, they want that wire. Yeah. So that's good. Okay, shall I push?
Push, please. Very nice.
Yeah, it's gone.